или его двинет вот так чуть-чуть сюда, да. Ну это камера, видите, это он происходит. Есть экран, да. То есть я, например, могу видеть там, но куда эти бумажки в руках, вот смотрите, рука, тут мы стоим, оно все видно. А бумажки, они будут падать, и тогда в руки я бы их вот сюда зацепила, может ее туда в бок сдвинуть.
А может вам распечатать просто вот так вот делать?
Это нет, это непривычно.
Непривычно.
Оно же глаз не будет так смотреть, понимаете?
Может быть, попросить, можно ли...
Ну это не сейчас, это уже завтра.
Да, потому что ему подвинулось сюда, а здесь как раз можно было положить.
И вот за вот эту
Да,
вот
да.
они лягут,
Да, и сюда
и
вот
я бы тогда могла бы, ну, их,
и вообще
знаете,
можно было бы вот так вот их двигать просто. Ну, не перекладывать.
да. Да не, ну я бы даже могла бы там куда-то положить, но, потому что когда на экране оно видно.
Hello, Dr. Pinchuk Maria Morera from the organizing committee. Nice to meet you. Nice to meet you.
Before we start, could I just ask if the people sitting at the back might like to come down a little bit for this session? It would be so lovely to have you a bit nearer. Go on. Yay. So we can communicate. No, the others aren't. Thank you.
How are you handling the questions, Julia? After?
Yes, so I think it would be good because it's sort of interact. You know, my hope is to try and bring it together and have a bit of a panel discussion, which is how the other ones have worked.
Yeah.
So what I would probably do is, if there were, as I said at the beginning, if there were any specific questions that people have, if you sort of, you're right there. If there are any specific questions that people have to ask, otherwise we'll kind of have time for a panel discussion and questions at the end is the plan for that. So I am going to start. We're good to go.
Oops. Okay, good afternoon, everybody, and welcome to this session, Substance Use, Suicide and Self-Harm, Epidemiology and Prevention. This is part of the thematic track on addiction and mental health, which is being co-produced by the Society, with the Society for the Study of Addictions. So I'm really grateful to the programme organisers for putting on this session. My name is Julia Sinclair. I am a Professor of Addiction Psychiatry at the University of Southampton, and I am a trustee of the Society for the Study of Addiction. So it's my absolute pleasure to be chairing this session this afternoon. As with other sessions, we've got three marvellous speakers. We've got 90 minutes, so we're going to have approximately 20 minutes each. There'll be a question or two if there's sort of things that you want to specifically ask after each one. But what I hope we'll then have is a panel discussion at the end of the three presentations to try and bring it together. So this session really came about by the sense that, you know, the overlap, as we've already heard so much in this conference, between suicidality, suicide, and mental health and addictions is really key, and at the moment not particularly well integrated. For me, this is a particularly important topic. Before I became an addiction psychiatrist, I was actually a suicide researcher, and this is what I did my higher degree on. And for me, one of the key things about this was when we looked at suicidal behavior, was that in those people for whom it resolved, one of the key themes in a work that I published back in 2005, a key theme was about the fact that if you're able to resolve the alcohol dependence or the harmful use of alcohol, actually the suicidal behavior resolves itself too. So I think it's a really important session that we've got today, and I'm delighted for the three excellent speakers that we have. Our first speaker is Solja Niemelä, who's a specialist in psychiatry with a competence in addiction medicine, and she's currently finalising her tenure-track professorship as an associate professor of addiction medicine at the University of Turku in Finland. She also has a position as a chief physician at the Addiction Psychiatry unit at Turku University Hospital. Her field is clinical epidemiology, utilizing population studies and register linkage data sets. Her main research interests are psychosis and substance use, as well as the prognosis of adolescent substance use. And what she's going to be talking to us today about is adolescent substance use, self-harm and suicide, and the findings from a Northern Finland Birth Cohort, 1986. So Solja, thank you very much indeed.
Okay, hello everyone. My name is Solja, and thank you for the SSA and Julia and Sarah for inviting me for this session. This is really great to present results from our research group. This is my disclosure for the past 36 months, and what my talk today, just a couple of slides about the background. I will present you what is Northern Finland Birth Cohort study, and then present our findings on adolescent alcohol and cannabis use, self-injury and suicide death. In EU, every year approximately 56,000 persons kill themselves. This is, if you look the all-cause mortality, suicide comprises approximately 1% of all deaths. But when you look at younger age groups of all mortality among persons less than 30 years, approximately 1 out of 5 of deaths are premature mortality due to suicide. So this really is a thing that impacts young people. Then we have a self-harm, which can be understood as a non-suicidal self-injury, NSSI, or suicide attempts. And these are highly prevalent among young people as well. There's quite a bunch of research done on excess suicide mortality and how it's associated with substance use, and most of these studies have been done concerning alcohol use. However, there is a paucity of longitudinal studies on adolescent substance use and subsequent severe self-harm and death by suicide. And especially when you look at the longitudinal studies which have been examining adolescent substance use and subsequent suicide or self-injury, they are markedly heterogeneous, especially accounting for confounding bias, because suicide as an endpoint, there are very many things which may affect this outcome. And I shortly introduce the Northern Finland Birth Cohorts. I personally live and work nowadays in southwest of Finland, in Turku, but I'm originally from Northern Finland, from Oulu. And I was working with the Oulu University, that's my alma mater. I got my MD degree from Oulu University, but I was working in Rovaniemi at the Arctic Circle up in Lapland for 5 years, and during that time I started to collaborate with the Northern Finland Birth Cohort studies. And this is a really truly amazing study. There are actually two these kinds of cohorts, Birth Cohort 86 and Birth Cohort 66. It was first established, and then they repeated it in after 20 years. And all these participants or their mothers were met at maternal health care in 1980s, and can you believe 99% of the target population participated in this study? So thank you, Northern Finland, for this. Yeah, and if you're interested about these cohorts, more information can be found from the Oulu University site. So the data set here is really extensive. It covers questionnaire data and clinical data from the 10 to 16 gestational week during the pregnancy, but also data at age 7 to 8 years, 15 to 16 years, and now the latest data collection point has been completed just recently, although there the attrition rate has been much higher compared to the previous data collection points. And for all these participants in Finland, like in other Nordic countries, we can use personal identification numbers, PINs, to link information from national registers, and all this data has been linked to the data which has been collected over the years. And when looking the adolescent substance use, there's a questionnaire-based data collected more than 20 years ago when the participants were 15 to 16-year-olds, but also information on their psychiatric symptoms and all sorts of data concerning the family background. Also like the parental psychiatric diagnosis, they have PINs for their parents as well, so register-based data for that is also available. And this data, it is served as open data principle, and it's available from University of Oulu, and permission to use this data can be applied for research purposes via request portal. Of course, it's good to have inside men, women, other within the Oulu University, but it's good to know that this is open data based cohort. So okay, the data what we have used in our studies has been collected at age 15 to 16 years old. Approximately 77% of them were followed up at age 15 to 16 years old, and there were two questionnaires, first questionnaire by post, and then there was this field study with the clinical examination where the participants filled in another questionnaire, and these questionnaires included information on substance use. Many questions on alcohol, also good package on smoking, and then lifetime use concerning cannabis, inhalant use, medication misuse, and so on. And these data have been linked to care register data. This consists inpatient and outpatient specialized care called HILMO, which is from the National Institute of Health and Welfare. And this data that we have used in these self-harm studies, it covers all the diagnoses from 2001 until end of year 2018. And information about death has been collected from the population register and the causes of death from the Statistics Finland. And when you link information using personal identification number, the attrition is minimal. It's basically like a couple of participants do some mix-ups with the pins in the data collection phase in the cohort, but it's really the attrition there is minimal. And how the death by suicide was determined, it was information from registry for causes of death with ICD-10 codes, intentional self-harm, and when suicide death is suspected, an autopsy is routinely carried out in Finland. The self-harm information was collected from care register. Here you can see the ICD-10 diagnosis codes, and it was also completed with primary care visit codes, ICPC2 codes, P77. And this definition of self-harm, it covers both non-suicidal self-injury, NSSI, and suicide attempts. And this is what we have used as outcomes. And among these participants in the 86 cohort by the year 2018, that is when there have been 33 to 34 years, 109 participants had at least one incident of self-harm requiring medical attention, and 29 had died due to suicide. And I think it's always, sorry about my black humor, but it's also been a little disturbing as a suicide researcher when you're like happy that, oh, there should be more who have been killed by suicide. So this is, but at least there were around 29 persons who had died by suicide, 0.0%. Luckily, not more, even though statistically it would be nice to have more in this group. Okay, and what we have used for statistical methods, basically, of course, the basic statistical methods, but to analyze the associations between adolescent substance use and later events, self-injury and suicide, we have used Cox regression, and then we have used to do the survival curves. We have used, instead of Kaplan-Meier, we have used this Ahlen-Johansen, which is a variation of Kaplan-Meier. It is supposed to be better in situations where there are multiple factors influencing the outcome and where the Kaplan-Meier curves may be a bit flawed. And we have also done additionally this Cox proportional hazard assumption for the same reasons to test this association parallel to Cox regression. Okay, and first I will present our paper written by Dr. Jonna Levola. This was just a couple of weeks ago accepted for publication in JSAD. And here we have studied the associations of adolescent alcohol use and self-reported alcohol tolerance with risk of self-harm and suicide in this cohort. And here you can see the alcohol use variable. What we have looked, age of alcohol use onset, age of intoxication onset, alcohol use frequency during the past 30 days. We wanted to use this one. Also the frequency during the past 12 months would have been available, but this will give like more precise estimate on problematic alcohol use among adolescents. And this is sort of a new approach. We have used this, we have named it as a self-reported inherent alcohol tolerance. There was this question when there were 15 to 16-year-olds that how many drinks you need in order to get intoxicated, and this was the categorical option, so unfortunately we couldn't do this as a continuous variable, but we made this three-class variable with low to intermediate tolerance, meaning less than 9 drinks for male and less than 7 drinks for females, which is really quite a lot for 15 to 16-year-olds. And those who reported that they need 9 drinks or more for males or 7 drinks or more for females, they were considered to be the high tolerance group. And this covered 10% of those participants. And 20 years ago, very intoxication-oriented alcohol use was really common in Northern Finland. Okay, and then we had quite a lot of different confounders. We included other types of substance use, what they have reported to use at age 15 to 16-year-old, but also the psychiatric symptomology using self-report questionnaire, family structure, parental education level, and parental psychiatric diagnosis. We ran in the analysis lot more different kinds of, and of course actually sex of course was included here. Sorry, I forgot to put in the slide. And included only those who were associated with less than P 0.1 with self-harm or suicide in the study. And here you can see the curves, and the red ones are the most heaviest alcohol use or earliest onset of alcohol use. And here you can see that the self-harm curves really go on their own path to in this predictive association for self-harm requiring medical attention. And for suicides, similar curves, although the number of those who had died by suicide, it was low, so there was the curves are not that pretty as they were for the self-harm. But we did these Cox regressions with the confounders, and we found that younger age for first intoxication, that means younger than 14 years old, associated with self-harm, despite of these other confounders, but also high inherent alcohol tolerance, and association with suicide death by age 33 years, frequent alcohol intoxication, and high inherent alcohol tolerance. There was the confidence interval was pretty broad, but it was statistically significant. And another paper published recently in Acta Psychiatrica Scandinavica by Alexander Denisov. He's finalizing his PhD thesis on sequelae of adolescent cannabis use in this cohort. And here we used the question concerning cannabis, have you ever used marijuana or hashish? And we had to dichotomize this because of the low number among cannabis, among those with self-harm and suicide and cannabis use. We did some post hoc exercises also with dose response stuff. But basically, this is really karvalakkimalli, which means really simple, really simple exposure variable. We used sex, also alcohol intoxication frequency during the past 12 months, other types of substance use. And here we would have wanted to use the youth self-reports, but there the attrition for those who had answered the YSR questionnaire, it was a bit lower, and this attrition would have dropped cases from the self-harm and suicide outcomes with cannabis use. But we included lifetime parental psychiatric diagnosis as well. And here you can see the associations of covariate self-harm and suicide death. And as you can see, the weakness of this study definitely is that even though the sample is actually what we know is the largest population-based prospective study on adolescent cannabis use and suicide, we here have only a couple of cases with suicide death and cannabis use. So this is just preliminary info, and we did this Allen-Johansen curves as this two-class variable for cannabis use, and here we can use that those had been reporting cannabis use, there was an association, crude association with self-harm, but we didn't see crude association for suicide, and this is probably type 2 error due limited power. But for self-harm, we did this stepping modeling with various confounders, and here we can see that even after that we have included alcohol use, other types of illicit drugs, parental psychiatric diagnosis, sex, and psychiatric disorders at baseline. We can see a statistically significant association between self-reported cannabis use and later self-harm. So But when looking these associations, it's really important that one should take into account also other types of substances, because here we could see that the crude association attenuated by 46%, and confounding is an important issue when looking at these prospective associations. Alexander did also this narrative review on cannabis and intentional self-injury, which was published just 1 month ago, and I recommend. I think he did a very good job with this. So at the end, we have shown in these papers that adolescent substance use associated with increased risk for subsequent severe self-harm and suicide. Maybe could this be implications for suicide prevention, or at least I think that when screening problematic alcohol use, it could be used as a proxy for other poor outcomes, and I think that self-reported alcohol tolerance as a novel measure for problematic alcohol use during adolescence, it's a good new tool to screen for problematic alcohol use. And the confounding issue is important when doing these studies, because as an endpoint, both self-harm and suicide, they are complex phenomenon, and variety of things may affect the outcome. Okay, that's my talk.
And thank you, Solja. Just before we can I ask a slightly nerdy question?
Sure.
Specifically to your talk, which is about where you were talking about alcohol use, in tolerance and the measure of tolerance, and that was, high tolerance was about 9 standard finished drinks. As we know that there are 16 different ways in Europe of measuring alcohol. What is the standard finished drink that went into that?
It's more than yours. Yeah, in that questionnaire, there was this pictorial examples for standard drinks, and one standard drink in Finland is 12 grams, not 10. Okay. So they drink kind of even more, and I feel that this 90 percentile cutoff, we actually tried to, because it was categorical question, and we tried to do it with a lower level, but there the amount of the middle group would have been so large that it was not that easy to point out that this is actually a good measure. Thanks.
Thank you very much indeed. We'll hopefully continue that discussion after our next speakers. So moving on to our next speaker, who's EveGriffin from Ireland. She's the principal investigator at the National Suicide Research Foundation in Ireland and research fellow with the School of Public Health at the University College Cork. She's more than 10 years experience in the area of suicide prevention, and particular interest in the epidemiology of hospital presenting self-harm, as well as program and service evaluation. She's authored more than 60 scientific reports and peer-reviewed publications on the topic of self-harm and suicide. And I'm really delighted that she's going to be talking to us today about restricting access to means, the public health approaches to reduce drug and alcohol-related self-harm. Eve, thank you very much indeed.
Good evening, everybody, and thanks, Julia, for that introduction. It's a pleasure to be here at this conference, and thanks particular to Sarah and to Julia for the invitation to come along and present today. So as Julia said, I'm a research fellow at the School of Public Health in University College Cork, and I also work with the National Suicide Research Foundation. And prior to that, I worked for several years as manager of a national self-harm registry in Ireland, and I'm going to spend most of, or all of this presentation really, talking about the data that we collect as part of that registry. So I'm going to talk a little bit about why we should focus on self-harm, why we do focus on self-harm as an outcome, and I'm going to present a little bit on what we know about the involvement of specific drugs and to a lesser extent alcohol as well in terms of self-harm presentations and some emerging trends around the epidemiology of intentional drug overdose. And then I'm going to speak about, I suppose, restricting access to means and how public health approaches that seek to reduce access to substances which can be misused and can be very effective for suicide prevention. So, as Solja has outlined, suicide is a significant public health issue. Globally, every year, about 700,000 people die by suicide. And self-harm is one of the strongest predictors of future suicide. So, and is associated with a significantly increased risk of suicide. So, when somebody engages in self-harm, their risk of suicide is 50 times higher than the general population. And so engaging with people who are actively self-harming is a really important point of intervention for suicide prevention. Not everybody who self-harms will attend clinical services, but emergency departments are a place where we often see self-harm presentations occurring, and I suppose clinically it's a really important source of information for us. Just in relation to the definition of self-harm that we use, it covers a wide range of motives, so not everybody who self-harms will have a wish to die. There may often be a wish to die, but it can also include other motives, and will also include a wide range of methods of self-harm, which we will see. So I suppose, just in relation to the monitoring of self-harm in hospitals, as I mentioned, in Ireland, we have one of the longest standing registries which monitors hospital presenting self-harm. That was set up back in 2002. And in recent years in particular, we've seen the establishment of more and more registries like this, which aim to report on suicidal behaviour over time. In terms of the prevalence, so we have about 5 million people living in Ireland, and we see about 12,500 presentations of self-harm every year. That's equivalent to a rate of about 200 per 100,000. Most of the self-harm that we see in clinical settings involve an intentional drug overdose, so about 2 in every 3 presentations. And the other common method of self-harm that we see, which is often combined with drug overdose, is self-cutting. And we also see alcohol involved in self-harm presentations. So this data is important, I suppose, at 2 levels. One, it's really important at a clinical level because it can tell us an awful lot about how we need to respond and treat and provide interventions at an individual level. But it can also be really important in terms of detecting ongoing trends, and often at an earlier point than suicide data can. So it's a minimal data set. We don't have a huge amount of data on comorbidities and diagnosis around substance misuse, but we know that between 40 and 50% of people that are recorded by the registry will have substance misuse issues. And we also see that there's a certain proportion of people who are then referred on to addiction services following their self-harm presentation. So here's an overview of self-harm involving intentional drug overdose. As I mentioned, it's the most common method of self-harm that we see, present in about 2/3 of all presentations. It's more common among women and young people, and almost half of the presentations involve multiple drug types, and 40% will also involve alcohol. And so if you can see this visual on the right-hand side, this gives you kind of an idea of the range of drugs that are recorded in self-harm presentations. Most commonly, we see that people will present with overdoses of minor tranquilizers, primarily benzodiazepines, which are often prescribed for anxiety. And we also see a high proportion of overdoses, including over-the-counter medication, most commonly paracetamol. Generally speaking, younger people will tend to present with overdoses using over-the-counter medication, whereas with increasing age, we then tend to see more kind of prescribed psychotropic medication showing up in overdoses. And you can see here as well that there's a kind of a significant minority of presentations which involve what we term street drugs. These may be illegally obtained drugs, or they may be legal drugs, but which are misused. And again, this is more common among men. We see more than 20% of overdoses or self-harm presentations involving street drugs. So I'll come back to this particular group in a few minutes. So we know that intentional drug overdose is linked with a higher rate of suicide and premature mortality, and this study that we undertook a couple of years ago estimated case fatality using two national databases, the registry and also a drug-related death index. And what we found in particular, and the reason why we did this, was to identify, I suppose, case fatality risk of specific drugs that are taken in self-harm. And we found that men aged 45 to 54 and those taking multiple drugs had a higher risk of fatal or suicide involving intentional drug overdose. And we found two particular drug types which were associated with increased risk of suicide. Tricyclic antidepressants, which had a 15-fold increased risk of suicide. Now, these are quite an old type of antidepressant, and even though clinical guidance actually suggests that they're not prescribed anymore because we know there is an increased risk of suicide in the registry, we continue to see consistent overdose patterns with regards to these drugs. And opiates were the other drug type that were associated with increased risk of suicide. Okay, so just to speak a little bit about some of the emerging trends that we're seeing in relation to self-harm involving overdose. The first is in relation to paracetamol poisoning. And generally speaking, we've seen an increase in the rate of self-harm among young people over the past 13 years or so. And in line with that, we've seen changes in methods of self-harm. And drug overdose among young people has increased by about 10% during that same period. And when we look at specific drug types, we've seen that rates of paracetamol-related overdoses have actually increased by the same amount. And this study, where we compared rates of paracetamol between 2007, 2012, compared to 2013 and 2018, we found an excess of paracetamol-related overdoses in young girls in particular, so a 23% increase in 10 to 17-year-olds, and an 8% increase in young adult females. So just come back to overdoses involving illegal or street drugs. Generally, these types of substances are prevalent in presentations where people are reported to experience homelessness. We often see these presentations to hospitals in inner city Dublin, in the capital in Ireland, for example. And generally, the other characteristics of these types of presentations would reflect kind of clinical challenges in actually providing treatment. So we see a higher risk of people not receiving complete care when they attend, maybe due to a person leaving without being seen or refusing medical advice. And we see a high rate of repetition as well associated with these types of presentations, which indicates that there's some sort of an unmet need in terms of the clinical response that's received at the point of care. I suppose coupled with that, we have seen a significant and quite stark increase in the use of these types of drugs since 2007, where the rate of self-harm involving street drugs has more than doubled and continues to increase. In particular, we've seen a 10% increase in cocaine involvement and a 15% increase in the use of cannabis. And I suppose Solja's research really speaks to the reasons why this is particularly alarming. And we've seen this increase both in men and women and also across all age groups. So in particular, among young people, we're seeing consistent increases. And just to speak about alcohol briefly, again, as Julia said at the start, the role between alcohol and suicidal behaviour is quite complex. But generally, it's thought, the general thinking is that, alcohol involvement in self-harm acts is taught to reduce inhibitions and increase impulsivity. And we see that it's more common again in men, and older men more likely to be coupled with a drug overdose. And there's also particular challenges with regards to treatment of alcohol-related self-harm. These presentations are more likely to occur out of hours, and they're also less likely to receive psychiatric care and often result in delayed assessments, for example. And when we look at the role of alcohol involvement in suicide, we see that actually alcohol-related suicide is more common among younger men in particular, and those with a history of drug or alcohol abuse. And this has been consistent for a number of years, but there has been a recent study from the US, for example, which has indicated that there has been an increase in female suicides where alcohol is taken prior to the suicide itself. So even though we advocate for a kind of a multi-level approach to suicide prevention, it often takes a lot of different activities at different levels of intervention. Consistently, one of the measures which has the best, I suppose, effects in terms of preventing suicide is restricting access to means. And traditionally, restricting access to means is focused on frequently used sites for suicide in terms of barriers on bridges or preventing access to waterways, for example. But in more recent years, we've become to, I suppose, understand the public health measures which seek to restrict access to substances which can be misused, or which seek to target general misuse of drugs and alcohol can be very effective in reducing suicidal behaviour. And I suppose there's a couple of reasons why we think that this might happen. I suppose, first of all, is that the substances taken in overdoses tend to reflect general population consumption trends and prescribing patterns. And also, most, not all, but most of suicidal acts are actually impulsive. And this is reflected in the source of medication. So most medication being taken that has either been, that's either stored in a home or is actually prescribed to that person. So generally speaking, when we've looked at kind of reducing access to medications, we've seen that restrictions, which are quite, I suppose, quite strong in terms of withdrawing from the market, have the best impacts. One very good example is coproxamol, which was withdrawn from the Irish market in 2006, following its kind of suspected role in a number of suicides. And we saw an 84% reduction in the 3 years following withdrawal from the Irish market without any substitution effect. With regards to paracetamol, there's been more mixed effects. We've seen reductions in intentional drug overdose and suicide deaths in the UK, and these have been sustained over longer periods of time. But we didn't see similar effects in Ireland. For example, we brought in similar smaller pack sizes, and we didn't see a reduction, for example, in the quantity of tablets taken. And more recently, in Denmark, they've shown that there was a 17% reduction in hospital admissions after the age limit was applied in Denmark, so only those over the age of 18 were allowed to purchase paracetamol as well as pack size restrictions. So there might be something in terms of country-specific effects, and one of the things that might be really important is public education, which is something that we're particularly concerned about in the Irish population. One other example which we have recently published on is restrictions that were brought in Ireland with regards to access of codeine-containing products. So in 2010, regulations were brought in by the Pharmaceutical Society of Ireland, which aimed to restrict the supply of codeine-containing products. So they were still available over the counter, but under the supervision of a pharmacist. They were also taken away from public view, and they were, I suppose, advocated as the second line of treatment for pain medication. And what we found was that we found a 20% reduction in codeine-related intentional drug overdose in the 3 years following this guidance. Again, we didn't see a substitution effect. Actually, we saw a smaller decrease in other drugs, but not to the same extent. And we saw that this impact was more pronounced among women. And we're currently working on a more longitudinal follow-up study of these particular regulations. And what we're actually seeing is that there seems to be a sustained effect of these regulations following that kind of initial decrease in the period afterwards. And up until 2019, we haven't seen any, I suppose, relapse of those particular regulations. Again, there's kind of some country-specific considerations here. For example, Australia, which brought in similar regulations a number of years ago, didn't see the same types of outcomes, and they definitely weren't sustained, but they did when they were up-scheduled to prescription. And finally, just this example with regards to alcohol-related self-harm. So a study we published a few years ago, we found that when we looked at self-harm around public holidays, we saw that the risk of alcohol-related self-harm increased by 24% on public holidays. In particular, this was most pronounced around the Christmas period, where interestingly we see a reduction in self-harm during the Christmas period, but actually an increase in alcohol-related self-harm across most of the public holidays. And when we looked at particular presentations on these days, we found that they were more likely to occur out of hours, they were more likely to involve ambulance care, and we found evidence of more impulsive presentations by men. So more first-time presentations on these particular days, and more presentations involving more impulsive methods of self-harm, such as self-cutting. Interestingly, the one day of the year where we saw a reduced risk of alcohol-related self-harm was on Good Friday, which up until 2018 was the one day of the year where we had alcohol-related restrictions in Ireland. Unfortunately, since then, those restrictions have been eased, but it perhaps gives some indication that those types of public health measures can be really important in terms of reducing alcohol-related self-harm. This is echoed in a recent literature review by colleagues in Australia, who found that, generally speaking, alcohol policies at a population level, such as increasing the pricing of alcohol or particular restrictions, generally speaking, had a positive impact on suicidal behaviour. So just to wrap up, I suppose, reflecting on the information that we gather as part of the registry and thinking about the gaps and thinking about where we should be focusing our efforts, there's two ways to approach this. One is in relation to how we do research and the type of data that we gather. And I think there's a lot more work that we need to do in terms of understanding the mechanisms by which these population level initiatives work, and I suppose understanding the context in which they are implemented. From a data improvement perspective, I think we really need to improve how we record and report on alcohol and general substance use within self-harm. For example, in our registry, alcohol prevalence ranges from 20 to 51% across hospitals, so there definitely is some issues with regards to alcohol reporting. I think generally speaking, we need to think about how we classify medications, and different registries and different systems use different approaches. More recently, we have been adopting the WHO ATC system, which has actually allowed us to identify important trends in less frequently used drugs. And we also need to have better information on, for example, the source of access of medication and where people access the drugs that they take. In terms of interventions, I think there's definitely room for targeted measures for substances with increased risk of fatality, especially those which maybe aren't frequently prescribed. And I suppose thinking about the role of psychiatry and pharmacy as well, community pharmacists, in terms of monitoring long-term prescribing. And finally, the integration of mental health services, which is something particularly in Ireland that we haven't really been successful with. but we can see that there's a huge overlap in terms of co-occurring substance use issues with patients that we see presenting with self-harm. We have a national clinical program for self-harm, so there are dedicated liaison teams who specifically treat people who present to hospital with self-harm. And in their model of care, one of their recommendations is that there should be an addiction specialist located in every liaison psychiatry team in Ireland, which hasn't happened, but that seems to be the direction in which we need to move. So thank you very much, and thank you to my collaborators who have worked on this with me. And if you'd like to find out more, you can visit our website.
I think we'll move on to our next presentation so that we can have time to talk. Thank you, Eve, very much indeed. And if we move straight on to our final presentation, and it's a delight for me to introduce my colleague from the UK, Navneet Kapur. Nav is Professor of Psychiatry and Population Health at the University of Manchester and an Honorary Consultant Psychiatrist at General Manchester Mental Health Foundation Trust. He spent the last 25 years, we're all getting old, Nav, he spent the last 25 years researching suicidal behaviour, particularly its causes, treatment and prevention. He's led committees for the National Institute for Health and Clinical Excellence, NICE, in the UK, and he sits on the main advisory group on suicide for the Department of Health in England. He's currently helping to lead a national quality improvement project to prevent suicide. He's the lead author of the Suicide Prevention textbook and has published over 300 academic papers on this. And he is the 2021 recipient of the American Association for Suicidality Award for Lifetime Achievement. Nav, it's a delight to have you with us today. Thank you.
Thanks, Julia. Hopefully you can hear me okay. I did fear the introduction was going to go on longer than my talk. I'm delighted to be here. Thanks to Sarah, SSA, and Julia for the invitation to speak. The invitation actually landed during the dark days of COVID, and this talk was originally going to be all about COVID, but things have moved on, and like COVID, this talk has evolved. So thanks for allowing me to be at your conference. I'm not an addiction researcher. I'm a suicide researcher. I'm a psychiatrist back in the UK. But one of the things I've realized in preparing this talk is that addictions might well be one of the forgotten frontiers of suicide prevention. So thanks for that. Okay, so this is what I'll do over the next 20 minutes or so. I'll start with a little bit of context. I'll move on to a little bit about what works for suicide prevention, and then I'll talk about COVID-19 and maybe where we go from here. So let's start with a bit of context. Now, quite often, we end up researching in kind of silos. We're always bothered about the statistics in our own countries, but suicide really is a global problem, 700,000 deaths annually. And the majority of the burden of those deaths isn't where I work or many of you work, but in so-called low and middle-income countries. That's where 75% of suicide deaths occur. So we need to adopt a global perspective when we're thinking about this. This is a paper from my colleague Dee Knipe and others. We'll make all the slides available afterwards. Click on the link. I encourage you to have a look at it. A global perspective on suicide. You're going to get lots of statistics from me. We love statistics as suicide researchers. But one of the things we never ever forget is that behind every statistic, there's a person that's lost their lives, friends, family, loved ones left behind. So it's an individual tragedy, but occurs in a wider context. Here are some data from England and Wales. What does it show? There are three things on this slide that I want you to look at. The first is that over a period of years, suicide rates have generally gone down, actually, which is great news. Similar pattern in many countries. The second thing I'd like you to look at is the difference between males and females. Suicide rate 3 times higher in men than women. Why is that? It's partly the methods men choose when they hurt themselves. They tend to use more dangerous methods. It's partly about help seeking. When I become physically or psychologically unwell, am I likely to seek help? Am I as likely to seek help as my wife? No, I'm not. I'm much less likely to seek help. And it's partly about risk factors. So suicide rates in men 3 times higher than women. And then the last thing I want you to look at is this little blip here. It's a little blip in suicide rates starting in around 2008, and that, of course, is due to the economic recession, the Great Recession, and again, this idea of an individual tragedy in a societal context. There's also other things behind all that data that I can't show you on the slide. One of the big things we're worried about at the moment is the rising rate of suicide in young people. Over about the past 10 or 15 years in the UK and in many Western countries, we're seeing a bit of a worrying trend in our young people, very sadly, ending their lives. Eve's talked a little bit about self-harm as a risk factor. So in the year after someone presents to my local emergency department having hurt themselves, they're at 50 times higher risk of suicide. But it's even more stark than that. You know, sometimes you'll still hear people talking about self-harm, oh, it's an attention-seeking behaviour, it's not serious. Well, it is serious. It is serious. And this slide kind of is another illustration of why. So the top line here is the life expectancy in men in the general population in England. And the dark bars here are the life expectancy in men who have self-harmed. So this is data led by my colleague Helen Bergen, data from 3 centres in the UK. But the message of that is clear. Self-harm leads to between 30 to 40 years of life lost. Okay? So anyone tells you self-harm isn't a serious problem, yes, it is. Okay. What causes suicide? Something that I'm often asked. Well, it's kind of complex. There are multiple causes. Genes, there's a genetic contribution to suicide. Early life experiences, stuff that happens early on, particularly adverse life experiences. Things that happen later on, relationship problems and interpersonal issues, financial issues. This corner here, that's supposed to kind of shorthand for psychological contributing factors to suicide, things like hopelessness, things like impulsivity, things like perfectionism. And I've spent most of my career in this corner here, so looking at the mental health causes of suicide, physical health causes of suicide, and of course why I'm here today, I mean, it's just alcohol up there, but we're talking about alcohol, we're talking about drugs, and we're talking about other addictions as contributing factors. And they're really important contributing factors. So this is a study we did a couple of years ago, a sample of middle-aged men who had died by suicide, a consecutive case series, nationally representative, and half of them had evidence of alcohol or drug misuse at the time of death, half of them. In terms of risk factors, if you look at cohort studies, the risk of suicide is increased between 10 and 20-fold if you have an alcohol or drug misuse problem. How do drugs and alcohol misuse kind of affect suicidal behaviour? So I'm glad we've got a massive screen here. So this is a complicated model from my mate Gustavo Turecki in Montreal. But really all I want you to look at are these two kind of little circles here. So basically there's a chronic effect of substances, so a mood depressant effect, their effect on a psychiatric disorder that might be kind of longer term, and then the acute effect that Eve mentioned, perhaps resulting in behavioural disinhibition, which is, may occur closer to self-harm and suicide. Okay. So you've had a little bit of context. I want to move on next to what works for suicide prevention. Eve talked about method availability. Now, why does restricting availability work? Well, it's because the build-up to suicide might be chronic, but that final decision to end someone's life can often be a snap one, can often be an impulsive one. So if you prevent access to lethal means of suicide, you buy time. The suicidal thoughts, suicidal impulses subside. People don't substitute to other methods necessarily, and you prevent deaths. And this is the best example I know. This is pesticide restrictions in Sri Lanka. Okay, so pesticides, common cause of suicide in Sri Lanka. These arrows are various pesticide bans. And what's the bottom line? Those pesticide bans saved 90,000 lives. 90,000 lives through restricting access to means. And here's the rest of suicide prevention, kind of my attempt to sum it up in a single slide. So what are the other things that work for suicide prevention? Well, there's other population-based measures. So the role of the media. So we've known this for many, many years. One of the things we're worried about is so-called imitative suicide. Dates back to the 18th century, The Sorrows of Young Werther, a novel by Goethe. Basically, the novel was published, and there were a series of similar suicide attempts across Europe following the story of this young man wronged in love. But, you know, there's contemporaneous examples. So 13 Reasons Why, a Netflix series, after it was aired, there was an increase in self-harm episodes. Examples from social media too. The key there is responsible reporting, avoiding undue reference to means of suicide. But other things as well, thinking about people who are bereaved by suicide, we know they're at greater risk, so care for people who are bereaved by suicide. Clinically, just assessments, a single assessment after self-harm can reduce the risk of repetition by 40%, just an assessment. But also the role of psychological treatments and sometimes, you know, pharmacological treatments get a bad press, but they can be effective treatments for depression and other things and can reduce suicide. So all those kind of clinical interventions are really important. I'm a big fan of guidelines. I've done lots for NICE in the United Kingdom, so I think they have a big role to play. And then doing lots of different things together. So safer systems of care can really make an impact when you do lots and lots of different things together. So that's a slide from the National Confidential Inquiry where I work. So that's what we know about suicide prevention, but what about the role of alcohol and drug intervention specifically? So, I mean, this is an example that will be very familiar to you, and it's about the kind of it's about the public health kind of interventions targeting alcohol misuse. A lot of these data are from the former Soviet Union. Here you go. So this is what happened to alcohol consumption. This is perestroika here. So massive political changes, alcohol quotas being introduced, distilleries being closed, vineyards being ripped up, alcohol consumption went down, and this very striking fall in suicide. Now, obviously, you know, that's an ecological study. This isn't cause and effect. There were lots of other things going on at the same time, but that is quite powerful and persuasive data. The individual level data, though, is much more kind of equivocal. So that's about intervening with a particular person who might have harmed themselves, or intervening with groups of people with alcohol or drug misuse problems to see whether it makes a difference to suicide or self-harm. So that data is much more equivocal, and I think we really need to be looking at that. As we need to be looking at interventions for drug misuse and interventions for other addictions. You know, gambling is a big thing. The association between gambling and suicide is currently a big thing in the UK. So opportunities there, I think. Okay, so the last thing I want to talk about is COVID-19 and what comes next. So do you remember what it was like at the beginning of the pandemic? I find it hard to remember, but this is what we were worried about, wasn't it? It was almost the kind of indirect effects of COVID maybe being even more severe than the direct effects. And people in particular were convinced that there was going to be a massive increase in suicide. In fact, what happened, this is a study that I said to my friend and colleague Jane Perkins in Australia could never be done, and then she went and did it. And 21 countries, almost real-time data, and basically suicide numbers remained unchanged, or actually in many places declined during the early phase of the pandemic. Why? Yeah, it's a bit of a paradox there. We know mental health problems, we know mental health worsened, by about 10% globally, if you believe some of the Lancet publications. Why didn't that result in an increase in suicide? Well, people have kind of hypothesized, removal of normal stressors for some people, stressors related to work, stressors related to education. It wasn't experienced in the same way by everyone. The much vaunted role of social cohesion, certainly that was in evidence early on in the pandemic in my neighborhood, people helping each other out, looking out for each other. Less social isolation for some people, less opportunity to harm themselves, more supervision. And the economic and policy mitigation, so labour paying people, keeping people in employment. All of those may have contributed. And of course, the other thing is suicide hasn't increased yet. That's the other problem, so the long-term effects of this. But I think as suicide researchers, we missed a trick. We missed a trick because we didn't look at other causes of mortality. So this was other data that was out around the time, and this is alcohol-related mortality. You had a talk on alcohol-related mortality in relation to COVID yesterday, I know. And there's this uptick in 2020, and what's intriguing about that uptick is it began in the second, third, and fourth quarters of 2020, corresponding exactly to the pandemic, an increase. And more recent data from the States suggesting that that increase in alcohol-related mortality is persistent. That's persisted. Drugs, again, here's some data from the States. The orange line is what would be kind of predicted on the basis of previous trends. The blue line is what actually happened. So an increase in drug-related deaths, mostly, it won't surprise you to hear, opiates. But things have moved on, haven't they? Things have moved on, and the pandemic is becoming, I think, less kind of salient. There's other things happening. We had a war in Europe. We've got economic turmoil, and permacrisis is the Collins Dictionary word of the year in the United Kingdom. It kind of describes what's going on, one thing after another. And the thing that I'm really currently bothered about and worries me is the role of recession. So we know recessions are bad for health, they're bad for mental health, they increase suicide. Here's some data from between the wars in the United Kingdom, a big increase of suicide associated with unemployment. There's similar data from the 2008 recession. Recessions are bad for health, bad for suicide. But interesting, I was wondering, well, what do they do for alcohol and drug-related deaths? So this is our go-to publication in suicide by David Stuckler in Oxford, but he also included some information on alcohol misuse deaths. For suicide deaths went up when recessions got worse. And for alcohol abuse, it's towards this line, so it's suggesting things may have got worse, but these confidence intervals are huge, they're really wide. And that reflects, I think, the heterogeneity of the effect. So the first thing is, actually, when unemployment goes up a lot, you get a big effect on alcohol-related deaths. But when it goes up a little bit, it's much more mixed. And for some people, some data from Europe that I've seen suggests that recessions are actually protective against alcohol misuse deaths, which kind of surprised me. The data here for drug misuse deaths suggest kind of protective effects. That's not my reading. Recessions are bad for drug-related deaths too. But we know how to mitigate some of these effects. Okay, so this is work we did as part of the last recession. Economists will tell you not all recessions are the same. Of course that's right, but we can learn from previous things. So, training of staff, training frontline staff to ask about economic difficulties, training them to signpost to relevant agencies, giving funding to advice agencies as well. But perhaps the most important thing are the policy implications, investing in active labour market programmes, provision of adequate welfare benefits. And that tells you something. Sometimes it's not about the recession. Sometimes it's about the policy response to that recession. And my colleague, David Stuckler in Oxford, has expressed it much more pithily than me. Recessions can hurt, but it's the policy response, it's the austerity that kills. But it's, I'm afraid, a bit more kind of doom and gloom, because that's not the only thing going on. The other thing that's going on is, health services were stressed pre-pandemic, weren't they? They were broken by COVID, and now they're shattered in the kind of post-COVID era. And that's what we're dealing with. And that's what we're dealing with health. But for drug and alcohol services, it's even kind of more stark, I think, in many cases. So in the UK, the fragmentation of drug and alcohol services kind of predates COVID, and it's a bit of a kind of disaster. We've got kind of frequent re-provision, some sits in the third sector, some sits in health. It's all a bit of a mess. And we're currently, as part of the confidential inquiry, going to do a study where we're linking various databases, we're looking at adverse data reports when tragedies do occur, to think about what we do for safety in those settings going forward. So I've told you a little bit about the context. I've skirted around what works for suicide prevention. I've talked a little bit about COVID-19 and the forthcoming economic difficulties. Here's a quick summary. So suicide and self-harm are important problems worldwide, and alcohol, drugs and other addictions are important risk factors. COVID-19 didn't result in an increase in suicide, but maybe we've taken our eye off the ball with some of these other causes of death. There's global economic challenges which are going to be bad for all kinds of things, but we know how to mitigate those. Health and social care context is going to continue to be challenging. We know what can help prevent suicide, but I think we need to know more about interventions which target alcohol misuse, drug misuse, and other addictions. That is one of the last frontiers of suicide prevention, and why I've been so happy to talk to you today. So the last thing I'd like to do is just acknowledge all the hardworking staff back in Manchester who do all the work while I just get to come to nice places and talk to you lovely people. Thank you very much.
Thank you, Nav. And if you want to come and sit back down here, I hope we'll have some questions from the audience. I think the key thing to do, please, if you do have a question, which I hope you do, we've got some time for discussion, please do go and stand by one of the microphones. There's one in this aisle here, where the cameraman is, and there's one in the other aisle there. I think it's been a really helpful session, and in some ways confirming the silos in which we work. And as Nav was saying, suicide rates go down, which we know they do in times of cohesion, and alcohol deaths have gone up. And I think part of that is the complexity of the relationship between alcohol use and suicide, because if somebody is suicidal, sometimes they're in psychic distress, and what they're looking for is to be removed from that psychic distress, and actually there's nothing like a bottle of vodka to knock you out. Now that, on an acute point of view, may then actually kind of resolve it at that time. But what I think we see in terms of the link between alcohol and suicide is the further people get down that trajectory, the more they have loss events, the more their kind of community and support disappears. I was interested to see the data that Eve showed, which was, the risk factor for, let me get this right, I took a picture of it, but the risk factors around suicidal, risk factors for alcohol involvement in self-harm was male gender, age 45 to 54, a drug overdose, presenting out of hours, and left likely to receive psychiatric care. That describes my population. They are denied access from psychiatric care. They're drinking the alcohol anyway, and the drug overdose is the means to do it. And so when I look at those, I wouldn't necessarily say those are risk factors. I'd say that's part of kind of the compound complexity that our patients have. So I suppose my question, whilst I'm waiting, Nikki's there already. I'll come back to my question in a minute if it's not asked already. So over to, first of all, Nikki Kalk.
Hi, thanks for really fascinating talks. So my name's Nikki. I'm a psychiatrist, an addiction psychiatrist based in the UK. And my question is really about how alcohol use is characterized in suicide research, because a fairly consistent frustration for me is that it's very imprecise, and I've always wondered why. Because we know that acute intoxication is a risk factor for suicidal acts. We know that alcohol dependence is second only to major depression in risk factor for suicide on a global level. But acute intoxication and alcohol dependence are very different things. And if I was to hypothesize, I would say general population strategies probably address the former, but not the latter. And so my question is, why is misuse used, not a diagnosis, in things like the National Confidential Inquiry, and is there a way forward in making things more nuanced, given that this is such a huge problem and such a modifiable risk factor for suicide, in terms of acquiring more precision about exactly what is going on with respect to alcohol in relation to suicide?
Who wants to start on that?
Yeah, can you hear me? Can you hear me? Yeah. No, it's a great question. I mean, we do actually record kind of diagnoses in the confidential inquiry. It's this big case register we have in the UK. But I think you're absolutely right. It's because, a lot of suicide and self-harm researchers don't bother kind of characterising things perhaps in the way they should be characterised. And I think it's probably even more complicated than the intoxication dependence, kind of thing. There's loads more going on.
Yeah.
But when I was, just kind of trying to pick out papers for the talk, this talk, I was surprised by just the paucity of research. So, researchers always say, don't they, we need more research. But I'm going to say that. But this time I actually mean it. I think we do. We haven't. We've just kind of brushed over the surface. But one of the key things, though, is that we shouldn't, sometimes I come up against this. We get caught up in kind of classifications, and we need to classify things better. The only reason we need to classify things better in this instance, we need to keep an eye on intervention. So that's what it's all about. It's all about kind of helping people. And so it's not about diagnosis for the sake of it, but I think better characterising the problem and thinking how we intervene, absolutely couldn't agree more.
But I think it does lead to interventions. And what I notice about suicide prevention policies that reference alcohol is they oftentimes talk about it like everybody has a mild alcohol use disorder and brief intervention is going to do it, or that everybody requires referral to secondary addiction services, and then you get diagnostic overshadowing. So hence, I think nuance is required, but thank you.
I agree.
Eve, did you want to add anything further to that? And could we have the lights sort of up to the audience and down on the stage so that we can see? Thank you.
Yeah, nothing to add to kind of what Nav had said, apart from what I had mentioned in my presentation, that we do have significant challenges in regards to understanding the role of alcohol as a proximal kind of risk factor around self-harm. And that's one of the issues, is that these types of registries and surveillance systems are quite useful at a general population level, but clinically it can be quite difficult to gather that type of information, and often it will be coming down to a doctor writing a clinical notes, alcohol plus, and so alcohol in our registry is a binary category, and it's very difficult for us to get beyond that. And I think also one of the things that I had made reference to is that kind of siloed thinking of the general presenting complaint, and if self-harm is involved, it's generally seen as being down to a particular team to deal with, and we don't have that kind of integration of specialities at the point of care. So it's a big problem, but we would love to work on that. And one of the things we are doing, which Nav had mentioned in relation to mortality data, is looking at integration and linkage of data systems. And I suppose one advantage in Ireland, and I know in the UK as well, is that most people who present to hospital with self-harm will receive a biopsychosocial assessment, and that has potentially huge amounts of information around ongoing risk factors and other challenges that individuals have, including diagnosis.
Thank you. And then we'll go
Yeah, from a clinical point of view, I think that about the interventions, what is a good intervention? I think it's pretty straightforward asking, do you have suicidal thoughts? And have you been considering that you might kill yourself? But from whom you should ask this, and where you should ask this? I think the emergency department is the place, because that's the place who gathers most of those who have problematic alcohol or other types of substance use, who are outside of substance use treatment. And that's the place we should really implement the interventions and asking about suicidal thoughts. I think it's it's cheap, but the question what happens after that you have to, if you start to screen, then you have to have the path to treatment, and that's the gap. I think we have the means.
Thank you. Tom, and then over here.
Thank you. Thank you for your presentations. Tom Phillips from University of Hull. Questions really about rationing of specialist treatment and its impact on self-harm and suicide presentations. There's a wealth of literature around the role of specialist treatment in reducing liver morbidity and mortality and hospital admissions from North America. We've also seen rationing of treatment in the UK because of austerity measures, which have displaced activity from specialist clinical services to hospital admissions. But little is assessed around the impact on self-harm and suicide, despite it being a common co-occurring presentation in clinical populations. So I'm sort of keen to highlight that your work, Nav, particularly does try and sort of model what access means, because the intervention might not be something novel that's needed. Maybe it's something we've already had and we need more of.
That's a really good point. I mean, we've done studies over the years where we've looked at kind of services and we've looked at kind of before and after trends. We haven't done that with alcohol and drug services, and we should. So we'll certainly kind of look at that. I mean, the message is, you know, specialist teams, when you get rid of them, that's bad. That's bad for suicide prevention. I can't imagine it's going to be any different for drug and alcohol teams.
There's another question, so we take that now. That'd be lovely.
Yes, thank you. Thank you for your presentation. It was beautiful to see this, what you called a little bit anecdotal evidence from the post-Soviet Union about the reduction of suicide rates when there were heavy restrictions. And it is on alcohol sale. And it is interesting that this kind of public measures, they are rarely viewed as a proper and really effective measure for suicide reduction. I come from Lithuania, where we have very high suicide rates, and would like to draw your attention to that actually there is an emerging evidence last year published by Shannon Lang and with co-authors in assessing Lithuanian alcohol control policy, which has been kind of relatively restrictive in the past years and has gone stronger. And we managed to show that actually increasing taxes very simply saved 50 lives, at least 50 lives of males, and actually had more effect on male suicide than female suicide. So there is emerging proper evidence. We had anecdotal evidence for a long time that these quite simple and really cheap public health measures, like a safer initiative by WHO, it actually works. So my question is, since we've known that in a way for a long time, we also know that treatment interventions and suicide treatment interventions work, but they're expensive. How come do you think that the public health measures such as taxation, restriction availability, how come they were so ignored in very many countries?
Okay, I'll kick off then. I can tell you exactly why. So you know, and I know in other bits of this conference you've discussed the kind of politics of kind of addiction and mental health, the impact on policy. And basically, when you're trying to influence policy, governments don't like policies that are kind of unpopular or difficult, and alcohol pricing is one of those. So in Scotland, you know, one part of the UK, they've gone for minimum alcohol pricing. In England, we've kind of shied away from that. But you're right, these kind of indirect public health measures, alcohol restriction is one. Increased welfare payments is another, you know, particularly relevant here. These things are, you know, in some senses relatively straightforward, but unfortunately, sometimes people lack the political will to implement them, actually. I mean, one of the things we've done is we've tried to model these, we've tried to present cost-effectiveness data. You know, it's tricky. It's evidence coming up against policy. That's what this is about.
Do you think that political will can be treated?
Yeah, so there are interventions. I've not done a randomized control trial of the interventions, but I have spoken to, you know, one of the funny things about researching in the same area for a few decades is you get to meet a whole lot of government ministers because they change regularly. I think it's just about banging away at the same message, keeping it simple and keeping it consistent. And then, you know, not for alcohol, but for other things, eventually you do get through. I don't know if anyone else has got advice. How do you deal with politicians?
That's for Ed Day, I think, to tell us about. But I do think there is a thing, and Tony Gual gave a fabulous presentation yesterday about, you know, the last century and how, you know, he looks back 30 years now and can see that all the work that he did about just getting an understanding of what a unit of alcohol was. And at the time, it seemed like it was just very slowly, you know, was it going to achieve anything? But actually, you look back on it now, and although it's different in the different European countries, actually, you know, we all now have this idea of a unit of alcohol. It allows us to then, perhaps in terms of screening, which may improve then data for suicide, to allow us to have, you know, proper screening measures using the FAST, the audit, whatever, which kind of has an understanding of, so that doctors don't just write ETOH++ or binges or shed loads or any other kind of really unhelpful, unprofessional thing, but actually will do a, you know, WHO standard screening measure, which then allows us to put that in the data set. And one of the things that I would do, which my public health colleagues locally in Southampton do not thank me for, is that Southampton now has twice the alcohol-related hospital admissions of somewhere in the northeast of the country, because they call it an artifact of the coding, but because we now systematically and in a sustained way screen everybody that comes in, and it goes straight into the electronic record. And so I think there are these things that it is about, you know, we need to know how to measure alcohol use. We then need to use standardized screening tools. This then gets into the national data, and then you can start to do it. So I do think it is very much a step-by-step basis.
And I'm sorry to barge in, because I don't hear the answer that I was actually expecting to come out first.
Which was?
And that is basically, it is industry influence. One of the reasons why politicians somehow don't have the will to implement proper measures that we know that it works is actually alcohol industry and their influence on politicians and also researchers. It somehow makes us a little bit unsober and blind in doing research somehow. So I think that transparency and also awareness, especially of clinicians. I'm a psychiatrist myself. So it took many years to actually be aware of how industry influences both our research, our thinking, and the way we do research and what we focus on. Because we tend to focus on very expensive interventions, kind of better interventions for treatment, better screening, better assessment, better research. Everything costs money. Yeah. And we tend not to even support or think about the interventions that cost nothing. That is public health interventions.
Thank you, and I would agree with that, and I'd also say at this point in the symposium, don't get me started. But there is, I mean, so two things I'd direct you to is that Alcohol No Ordinary Commodity is about to come out in its third edition, which has been supported by the Society for the Study of Addictions, and I'd encourage you to get to that, because that talks very, very, very eloquently to that, and we've had that as part of a session to this conference, or it's tomorrow. The second thing is about that, which is, and I didn't have my declaration of interest at the beginning, but I'm absolutely clear that I receive absolutely no money from the alcohol industry, the tobacco industry, or the gambling industry. And I think we need to be clear about that, because I think, those things, whether we receive money or work or sit on advisory boards or whatever it is, I think gives them lobbying power. So I think, the transparency in that process is something that we do need to be really clear about. And I suppose in terms of this panel, you know, because we've been looking at the sort of the data and what is under our control, I suppose that's the blind spot to that. But you're absolutely right. It's out there, you know, as part of global capitalism, and it's, you know, there's very little that public health can do from the marketing side of things against that. But we need to keep chipping away at it, as we've shown in our country that Scotland has and England hasn't. So, you know, it's another natural experiment. Are there any final questions for the panel at all? It looks like no one's else at the microphone. In which case, I think we will stop because we've got another fabulous session starting in 10 minutes' time. So if you wouldn't mind joining me to thank all of our speakers again. So that's Solja, Eve, and Nav. Thank you all for your contributions very much indeed.
Thank you. That's very good. Thank you.